clinicians. Oops. There we go. When you're kind of when you're dealing with with providers who just really want to start treating the test results itself. So so with that, I'm going to kind of start with a vignette. There we go. And so just to really kind of give you, and I think we've kind of touched about this before, but just again, kind of these are the typical, I want to present a typical scenario that we commonly encounter how that triggers the prescribing of antibiotic therapy. So this vignette is an 85-year-old man from a local nursing home and was referred to the local ER for evaluation of a change in condition. Very common. Speaking from someone who worked at a nursing home, that's that's something we encounter quite often. And many of these elderly patients, this patient has benign prostatic hyperplasia with some lower urinary tract symptoms. So many of these are going to have issues with urinating, urinary hesitancy and frequency. And this patient also has a history of a stroke where the residual left-sided hemiparesis. He has also a compression fracture of L2, L3, as a result have a chronic low back pain. And he takes medications for pain control, predominantly gabapentin and occasionally needs opioids. Now, he recently had suffered a fall injury, which worsened his back pain. And because of that, his physician adjusted his pain medication regimens. And so 3 days prior to his presentation, the nursing staff have noted that this patient is more somnolent and he's having more challenges with needing more assistance with transfers and ambulation. So to kind of make the nurse and the nursing aides' life a lot easier, the physician placed an order for a urinary catheter to be placed. Now, the patient hasn't been febrile and he's been fairly stable otherwise. So, and the only thing other than the somnolence of the nursing staff had noted that he's not eating and drinking as well, and his urine appeared to be dark in the collection bag. So because of this change in condition, his physician felt it necessary that he should be evaluated further in the local ER for possible urinary tract infections. So in the ER, the ED physician noted that he was arousable, but kind of falls back into sleep very quickly. His vital signs showed a slight, he's afebrile, slightly tachycardic, but other than that, more normal tensive, and he's oxygenating well on room air. And the physical exam was fairly unremarkable, except this patient has a urinary catheter, and then that the urine in the collection bag was dark but clear. And now, as typical of these presentations, many of the clinicians would typically order laboratory blood works, urine studies, and head CT, and these are the following results. So now, and just look at it, the CBC shows a little bit slightly elevated white blood cell count with predominant neutrophils, otherwise relatively unremarkable. Is chemistry levels, Chem7 shows mildly elevated BU and creatinine, and slightly elevated glucose. Urinalysis, it shows 2+ leukocyte esterase, nitrate positive, and a microscopic exam showed that there was 15 white blood cells per high power field and the presence of bacteria. And finally, a head CT, always typically get ordered in these scenarios, shows some age-related atrophy, but didn't see any acute changes. So the question is, does this patient have a urinary tract infection? Because this is a very common as I pointed out, a very common presentation in ED, a change in mental status or something that's out of that caregivers don't seems off to them, will typically get assume that this is a urinary tract infection. So the question is, does this patient have a urinary tract infection? But and commonly, the answer is that the clinicians feel like this is likely to be the cause of the change, and they usually result in a series of interventions, antibiotics as well as IV fluids. But more importantly is that it depends on also how the clinicians interpret these results, right? So can we assume that because there's bacteria in the urine that this could be a UTI? Because this is commonly, we hear this, I hear this quite often and such. And I think that, as we're kind of talking about the, using the urinalysis, that there are a lot of caveats that either are not really disregarded or not really considered and in the context of the patient. And we just and there's this drive to make the diagnosis based on the results rather than kind of incorporating and interpreting the results based on the context of the patient. And the reason I bring this up is because this is a chart coming out that's a table from the 2016 IDSA guidelines on treatment of asymptomatic bacteriuria, and this is to show the prevalence of asymptomatic bacteriuria in various populations, and it ranges from very low to almost 100%. And so it is important to kind of keep this in mind and remind, and as you're kind of designing your interventions, that yes, that many patients will, a substantial proportion of the population will have bacteriuria, even though the mantra that most medical physicians and the other providers are to say, if there's bacteria, it must be an infection. But as you can see, the survey shows that the prevalence of bacteriuria, asymptomatic bacteria, is fairly high, and depends on up to 100% in someone with a long-term indwelling urinary catheter. So we certainly, from this, we can't just make the assumption that the presence of bacteria can be, use that as an indicator for a patient to have urinary tract infections. So these are some of the questions that kind of come through it, because we really need to ask. So there are some questions we as antibiotic stewards will have to ask them, ensure as we're addressing antibiotic use, is how providers and clinicians are using, how are they determining these diagnoses? And so the first question is that we do really have to ask is, are pyuria and bacteriuria pathognomonic for urinary tract infections? This is very common because almost always, very, very common, even in my, when I review some charts, ER doctors will always say the UA is positive for UTI. And what does that mean? And in that sense, is how did they, why do they think that? So those are, but it comes down to is a lot of it is identification. Certain abnormal results will trigger that, but are they really truly, pathognomonic for UTIs? The other is can we just use do diagnostic testing to make the diagnosis of UTI? Because we do this also. That's very common as well, regardless of the symptoms. So that's another kind of how clinicians perceive testing influences how they perceive the test results. How would they diagnose patients? And finally, is that can UTIs be diagnosed the same way in all scenarios? Can we diagnose UTIs the same way in women as men and women, between women and men? Can we diagnose UTIs the same way between someone with a catheter or versus no catheter? And certain age groups, there's all these different scenarios, as you kind of see from the previous table. Asymptomatic bacteriuria ranges from different, exists in different population, certainly in varying degrees. So, but can they be diagnosis? But can a UTI diagnosis the same way how everyone does it? So those are questions that we have to really ask, and then how we're going to address those. How we're going to address the clinician behaviors in their diagnostic path and their diagnostic process. So this is kind of mostly the how UTIs are diagnosed in in a lot, and at least, if you pull up up to date, this is what they're going to say. So it's a combination of clinical presentation followed by diagnostic testing. So we know the typical symptom: dysuria, urinary frequency, urinary urgency, some suprapubic pain, somewhat flank pain if there's may have pyelonephritis, fevers, chills, nausea, vomiting. Those can also occur. But and then there's this component of diagnostic testing. We use the presence of leukocytes in urine or presence of bacteria in the urine. Unfortunately, there are not many great studies looking at just using the individual points to say how specific are those findings in the diagnosis of a UTI or for that matter sensitivity. But it's most clinicians are most experts who are looking at this it's really a combination of presentation followed by a confirmation of using diagnostic testing. However, in reality, that's not how it works. That doesn't happen all the time, right? Many UTIs are diagnosed by testing alone. As I kind of point out with my experience with reviewing charts of ED physician, even the hospitalists, many hospitalists would do this. They see an abnormal urinalysis and they diagnose the UTI regardless, without even considering this if there is any correlating symptoms. And with that, there are multiple studies that have demonstrated that abnormal urinalysis is the main driver for ordering urine cultures. So, and again, knowing that a huge percent of the population, have asymptomatic bacteriuria, this triggers another test that will also serve as a driver for diagnosing UTIs. And then many and something that a little bit more specific to urinalysis, but not a little bit, but other diagnostic tests have occurred is that many of these tests are not really ordered with the physician actually aware of this. And I think we had last year we had that guest speaker who came and mentioned that she went to she was in Alaska, where in the ED every patient gets a UA. So one of the problems is that these tests are being performed without even the patient, without the clinicians aware of them happening. And so they respond more, and unfortunately, as kind of going back to the first 2 points, is that they respond to the abnormal results, but not really understand why that test was ordered in the first place. And then finally is that there is also this, we're as physicians, clinicians are really trained to being trained to think things very algorithmically, and so that things have to follow a certain ways, and so we are now and in addition to that is that there's this whole big fear of that we may be missing some diagnosis. So a lot of time and out of convenience is that the tests like urinalysis and certainly blood cultures, urine cultures, respiratory cultures are often ordered as part of this pan culture strategy. And here I mentioned about fever and sepsis, but even just this non-specific symptoms like that patient that just came in that was in the vignette. So now, I'm kind of bringing up all these issues really to kind of point out that some of the challenges of testing, but I want to go through a little bit of detail about what is in an urinalysis that should what are they think what clinicians are thinking, or what are they using to make that results, especially when someone says, okay, a patient is positive for the UA is positive for UTI. What does that really mean? So if you look at the urinalysis, it's really 3 main components. So there's the gross examination, which is essentially a visual description, or actually more older description of the urine itself. What color it is? Is it dark? Is it yellow? Is it red? Is it black? Depending on certain conditions. Is it opaque? Is it clear, or is it turbid? Is there something kind of swishing around in there? And then the odor, certainly, more in the pediatric population, the maple syrup urine disease is something that pediatricians used to use. But again, nowadays it's more, oh, the urine smells strong, oh, or they smell foul, and that's a lot of times being used to trigger ordering a urinalysis. So so that's a first component. The second is the chemical analysis. And and there's several different tests on there. There's specific gravity, pH, protein, hemoglobin, but also and glucose. But then the two other ones that a lot of clinicians tend to use, leukocyte esterase and nitrites. And I'll go in a little detail about what they actually are. So you have that component. And that's where for those who perform urine dipsticks and such, that these are usually are determined by a colorimetric process. It turns color after specific color or shades above a color, and you're kind of reading it off of a reference card as such to determine the specific the values of each of those components. And then finally, if this is a urinalysis with a microexamination, these are things that are being looked for in a urinalysis. So, and usually this is a urine that's spun down, and then a drop of that is put on a microscope, and a experienced technician review the slides, and usually look for white blood cell, red blood cells, epithelial cells, but other things can pop up: casts, red blood cell casts, white blood cell casts, crystals, various crystals could appear, as well as microorganisms like bacteria, yeast, even parasite, protozoans such as trichomonas and such. And occasionally they do also see sperm cells in there. So these are the components of a urinalysis. But none of these tests are specifically directed toward diagnosing UTIs. And I think that's a big point I'm trying to make. These tests are really designed initially for the nephrologist to evaluate patients with renal diseases. So it's important to kind of keep in mind that the test itself was never designed for that. So comments like positive UA for UTI makes absolutely no sense when it was never designed to detect or to diagnose UTIs. Now, as I'm gonna go is that this slide will just go down with a little bit of some of the breakdown of some of the components that most clinicians use to make the claim of a positive or negative UTI. So nitrites is essentially a breakdown of nitrates in the urine by members of the Enterobacteriales bacteria. So, and that essentially is, so the presence of nitrites may suggest the presence of bacteria in the urine. Now, what does that tell you? That's all it tells us. It doesn't really tell us any other details, about that. So there's a lot of assumption built into that when a nitrite is positive. Leukocyte esterase, it is a breakdown, is essentially released during a breakdown of neutrophils of macrophages. Again, we use this try to use this indirectly as reference to the presence of white blood cell, especially in the case if you're not able to do a microscopic examination. Then the microscopic examination: white blood cells, red blood cells, bacteria. So there was a direct visualization of those components. So really, what clinicians, when they talk about positive UA, they're really kind of talking about the presence of nitrites or leukocyte esterase, white blood cells, and bacteria or red blood cells. But the key thing is to keep in mind is none of this is specific for urinary tract infections. So, and that's part of the problem, because many of these can, well, maybe not nitrites, but leukocyte esterase could exist in other medical conditions: white blood cells, red blood cells. And then the question about bacteria in the urine comes down to something we'll touch on is does that mean it's actually from it really depends on specimen collection. Is it collected properly or not? If you get a poorly collected specimen, then the presence of bacteria doesn't really tell a whole lot. So there's kind of keep in mind. And then finally, as I pointed out, is that the asymptomatic bacteriuria, right? Well, again, so there are going to be those who are going to have bacteria in their urine, regardless, outside of but but do not have urinary tract infections. So again, my emphasis on wanting to point out is that these may help confirm diagnoses, but it doesn't make the diagnoses because there's so many of these tests are non-specific. As we're looking at the patient care pathway, and this is kind of something we're part of a slide from a paper I'm working on right now, is kind of looking at how different steps of how testing and different sites, how the diagnostic testing influence the clinician's decision on, on ultimately on what they're going to do with their patients, and it starts really at the beginning, the decision to order the test, and because or even not, or even if the physician didn't, clinician didn't order a test, that the test being automatically ordered will kind of trigger a cascade of different things. And the green portion is really kind of to point out what are some of the interventions that can be done in terms of diagnostic stewardship, and then the orange part is really part of that is showing what can be done during that pathway can influence prescribing habits. And I'll kind of talk a little bit about that in the subsequent slides. So ultimately, as I kind of point out, is if what drives clinicians to start, even consider antibiotic therapy is dependent on test results, then we have to look at the question is, should these patients be tested? I mean, should all patients be tested, and which tests? I mean, and certainly that approach I mentioned about every patient coming through the ER getting urinalysis is inappropriate, because not every patient should be tested, and because of all the things I mentioned before. So it's important as we're kind of considering the what interventions, how clinicians, how do we can influence some of the things, and the decision to test is important. And so, we know that for during a diagnostic pathway, clinical presentation should be part of it. Remember that when I presented the slide to talk about how UTIs are diagnosed, that it has to start with the clinical presentations, right? Dysuria, urinary frequency, things like that. But then there's also other components, risk factors. This is if a clinician's considering a urinary tract infections, are there other factors in addition to the clinical presentation that could increase the probability, which is what clinicians really need to we try to get clinicians to consider. Are there other things could explain the clinical presentation? So we have as you're designing these interventions, well, I want to kind of bring that to a clinician's attention is, does this patient if you're going to test for this patient, does this patient have what you think they have, or the likelihood of this patient to have? So that leads to kind of choose, if that seems to be, I think that there may be a urinary tract questions, and then the clinician really needs to decide then the next set of things that clinician needs to consider is to choose the right test, because again, is the urine and these are some of the questions that you should we need to consider. What are the questions that the clinician is asking? And that's a really hard thing, because most clinicians don't really think about, I want to diagnose a patient with a UTI, but I want to just have something to tell me what's wrong with this patient. And so if we can't get a specific answer, getting the test, choosing the test will be very challenging for the clinician, and they will often choose tests that are not appropriate for the testing, and will get an answer that really that's not really what they're intending, or what we want intended that could lead to misdiagnosis. The other things that clinicians need to know is, what does the test do? As I pointed out, when clinicians order a UA and say positive UA for a UTI, is that what the test actually does? No, I mean, because and that was really kind of why I wanted to show those components of the urinalysis, because that's not what the test does. It doesn't tell you the patient has a UTI. It has all these little different things from which can be abnormal in certain circumstances, but none of them are pathognomonic for a UTI. So have to understand the clinician, help the clinician understand what the test is trying to, or at least for them to understand what the test is trying to do. And then the next question is asked, will the test result help answer the clinician's question? If it doesn't answer, and again, if it doesn't answer it, then it's really not an appropriate test to order, because, and it doesn't have to be for UTI, but but let's say, if someone orders a urinalysis for other reasons, like a urine drug screen, but then they see these abnormal presence of leukocyte esterase and such, but doesn't answer that question, certainly you can see where that, where this could lead clinicians to make the other diagnoses. Test interpretation is a really big thing. And again, because of the fact that most tests do not directly give the answers, clinicians still have to interpret what those results and put in the clinical context of that. And the clinicians don't understand that or have the appropriate knowledge to do so. It also creates misdiagnosis of those patients. And finally, is this patient applicable, the test result, and test result applicable to the patient being considered? And this is kind of more the notion of the post-test probabilities. Once you have a result, does this patient really have what you think it is? And that's, if it doesn't make sense to the patient, then you really kind of have to the clinician really needs to go reevaluate what that result meant, if it's pertinent to the patient. And that's another thing that many clinicians don't really readily do, because they kind of take results for face value. And that's kind of where they get into, start making decisions that may be contrary or not consistent with what the patient actually has. So these are kind of the first, before the test or order, is assess if this is the right patient, and then choosing the right test. Once the test is done, other things can actually, there are many things, and many of us are unaware of this, can influence the results of the test. So as I kind of pointed out about test interpretations, we also have to worry about how the test is being run, so make sure that they're done appropriately. So one of the big things is how specimens are collected. And I think many of us know or are familiar with how urine samples are collected, right? We ever talked about the midstream collection, where, that we ask a patient to appropriately, or actually cleanse their urethra, and then ask them to kind of pass that first few milliliters of urine before catching it, so that we would minimize any potential contaminants or whatever debris in the urethra, so that it will give a better that sample is more representative of what's in the urinary bladder. So ensuring that these that samples are collected appropriately, whether it is midstream collection using intermittent catheterization, so-called in and out catheter, but also other things I have to consider. And this is really important, because clinicians do this often blindly without context. Is let's say a patient has a urinary diversion, whether they have a percutaneous nephrostomy tube or something that or even an ileal conduit. Collecting those urine is problematic, because those because they're always going to contain bacteria or going to have some abnormal findings, but doesn't correlate necessarily to what's really going on with the patients. But the test itself will not differentiate that. So again, if we we do need to be cognizant of how these samples are being collected, and encourage our clinicians or provide an intervention that will remind them that interpretation of these results will be abnormal if you choose to go forth with testing the urine the same way as you're testing for other UTI, someone without those devices or issues. Then the other component is making sure that the specimens are appropriately stored, right? They have to be in sterile containers. They need to be refrigerated, especially if you're considering to culture them. And because again, if they're not properly stored or or in certainly a sterile container, there is a chance of getting abnormal results. That's not really because of the patient, but because of how they're being handled. Now, testing process is something that I want to just touch on, not something that I want to go into much detail, but as I kind of pointed out, that there are certain indicators that certain things that could make about specimen collection that is of concern, and there's certainly indicators about the quality of specimens. So the presence of epithelial cells, for example, is very commonly used as an indicator that this is not a clean sample and we shouldn't test. So processes in the laboratory to look for those things could also help with screening out to prevent misdiagnosis because of these other factors. So and there are laboratories that use specimen rejection policies where they see, again, you instruct the lab techs to look for specific findings, and if that findings, it triggers a rejection, and usually the clinician can notify about that. The other is testing algorithms, and that's and that comes down to a lot of, how the lab should also handle the testing. There is some discussion about using, trying to avoid having clinician order both UAs and urine cultures because of for various reasons, obviously because of the asymptomatic bacteria. And so having try to use an algorithm so that will limit, if a urinalysis is normal, then that there's no condition that the urine cultures would not be performed, or if the urinalysis is abnormal, then a urine culture would be performed, could help reduce some of the identification of bacteria that may be asymptomatic. There's a lot of debate about how great that is, but does something that's been in the literature for a while, to kind of discussion, and something that some organizations have elected to do to reduce the number of urine cultures. Mostly it's for urine culture, the cost of urine cultures. That's because of so many are being performed by their clinicians. The last component about this whole diagnostic stewardship is, and the clinical pathway, is how is that test result being presented? Because that ultimately is going to what drives the clinician for how they're going to take that information and then act on it. So certainly, if a and there was a paper that was published about a year ago that suggested, to limit the reporting of urinalysis. And for those of you what I'm don't know what I'm talking about, is that most urinalyses, when they're ordered without any specific indications, and all the components are being reported out in the results. So if a urinalysis is being ordered because of let's say for someone with kidney disease, then only the component that would be specific for the kidney disease would be reported. And that may help minimize. So the need for just do microscopic examination like white blood cells or bacteria would be excluded from that. And how the clinician perceive that report it will help guide them, really avoid for them to be the trigger for them to feel compelled to make the diagnosis of UTI and then subsequently start antibiotics. The other part is including comments, and that's a very common use. And for those who are doing urine cultures and such, especially urine cultures, I think many sites are would include comments like if they're identify 3 or more organisms, they usually will comment about that to help clinicians to understand that this is not really a valid, that there's likely to be a contaminated and poorly collected specimen, and you should not interpret this as a positive result. So that sometimes can help, and that's used a lot in many culture results, as well as certain other the test reporting. So now ultimately going back to urinalysis is here are the challenges of using urinalysis to make diagnosis. And one is that urinalysis don't reliably diagnose UTIs. As much as clinicians love to use this one litmus test to say, yes, my patient has a UTI, or no, he doesn't, or she doesn't, is that that's not what the test is designed to do, and does not reliably do that. So, and more importantly is that you can't use this for a one-size-fit-all approach. Someone with a chronic indwelling urinary catheter will always have pyuria and bacteriuria, and that doesn't mean anything if they're without symptoms. So again, using UTI urinalysis as a one-size-fit-all approach definitely doesn't work. Now, a lot of times, this urinalysis are probably better at ruling out UTIs than ruling in. So yes, there are times where you can maybe be able to use it, but it's like the D dimer. If it's negative, it's great, but it's positive, it doesn't really mean anything. I can tell you specifically if this patient has a PE or not. So it's in that same context. And remember, urine specimen collection techniques have a great impact. If you have, and as I tell people, if you give at the lab crap, you're going to get a crappy result. So if you don't, so it's important to understand that there are so many little factors that we are many clinicians are oblivious that can influence those results. And if we don't address those, we're constantly going to continue to have issues with clinicians inappropriately order antibiotics because they think that the patient has an infection. And just to give you another example is probably along this line is the positive contaminated blood cultures, and that is a case in point where if the blood sample is not properly collected and there's a positive growth, if we don't train blood phlebotomists and sample collectors the proper technique, we're going to experience high, and many sites have had experienced it, facilities have experienced a higher incidence of blood cultures contaminations. But until someone deemed that to any growth in blood cultures are always deemed significant. And that's another example, similar example of where specimen collection techniques is very important. And finally, as with all results, they have to be test results have to be interpreted and have to be include some clinical context. So in summary, it's like UTI is really a clinical diagnosis. There are going to be different criteria to use to diagnose different types of UTI because urinalysis itself is not going to be, it cannot differentiate in certain situations whether the presence of pyuria is actually due to a UTI or something else. Very important, this is with many infectious disease, laboratory data provides support for the diagnosis of UTI, just like any other disease. It does not make the diagnosis. And then there are also many other factors that affect the result of urinalysis, and kind of have to, as you're designing any interventions, you have to kind of be, you kind of have to look at how your clinicians are reacting to those results and how you can intervene. With that, this is all. I am open to questions, so you can get out of this and such. I hope this just find this is a little helpful and give you a very different perspective of what the urinalysis and its influence on clinicians. And I mean, again, this is a prime example. This is a quintessential kind of thing. Like every site I see that. So yeah, any thoughts, questions? Yeah. Oh wait, you're back on mute.
You can mute it there, Katie.
Oh.
All right, so it looks like we have a question for you, Dr. Koo, from Katie, and Katie's actually in billing. So if you haven't met her yet, she's a lovely resource. She's the IP over at the rehab hospital. So she asks, so when a provider orders a culture from an outside lab on a specimen that didn't trigger a culture based on their culture criteria or protocol, what would be some of the clinical indications to do so? And I can read that again if you'd like.
Oh, I see it in front of me. I'm trying to make sure I understand the question. so your question is it appropriate to perform a urine culture on a specimen collected from an outside of your facility? Yeah. So those so I'm assuming you're sending it to us. So now that gets a little tricky. This is one of the flaws of diagnostic stewardship, because I'm assuming you're referring to Billings Clinic. We do have what we call a conditional reflex urine culture, where if the initial urinalysis is abnormal, it meets a certain criteria, not abnormal, but a criteria. And that's usually a set number of white blood cells and presence of certain things. We would allow that specimen to undergo culturing. Now, if it doesn't meet, we would so let's say it's an absolutely normal urinalysis, it would not trigger that. Now we decide, is that a intervention we chose to go with to reduce inappropriate urine culture ordering, because we have seen a high number of urine cultures that are being ordered outside, regardless of actual urinalysis. So people just ordering urine. Again, going back to that, if there's bacteria in the urine, that must be a UTI. So why do we need a urinalysis? Let's just go straight to a urine culture, because it gives you all the answer you need, right? It'll tell me if it's a UTI, and then I know what bug it is and what antibiotics to use. And that's again, going back to the asymptomatic bacteria, that we know that is not, you can't use cultures in that way. Now, there are going to be certain circumstances where you want urine cultures outside of the urinalysis. So patients, pregnant women, women who are pregnant, patients who are undergoing invasive urologic procedures. Those are ones we do actually allow those urine cultures to be ordered, because those are the exceptions to the rules where, yes, you do want to treat them before you, even if it's asymptomatic, before, because of, in pregnant women, their risk of pyelonephritis goes up, and then certainly urologic, because they're invasive, they can develop urinary tract infections. So but again, most of our interventions are looking at 95% of the cases, not those exceptions, and that's the foul. So when you're designing it, you really have to actually speak with all these key stakeholders and get their input, and essentially have to create a separate set of orders for them, so that they don't have to go through this process.
Dr. Koo, kind of a follow-up question on that. That was really great stuff. Thank you very much. So if you had, say, a group of physicians, orthopedic surgeons, that commonly order a urinalysis prior to procedures, how do you comment on that? Are those appropriate for, I mean, what are they getting those for? Is it just, are they looking for potential for, UTIs, or that leads to a urine culture? Are they using those appropriately, in your opinion? What do you think about that?
So the notion of obtaining urine cultures as part of their preoperative screening process kind of stemmed like several decades ago, where there was a notion that yes, someone with existing UTI. Back then, no one really recognized asymptomatic bacteria, but so everyone with a bacteria in their urine is UTIs, right? And so that needed to be treated, because that could because the fear is that it would promote post-surgical complications like infections and such. And that's since then, there are multiple studies had not shown any any correlation to that, as well as any improvement in patient outcome if you do if they chose to treat the positive urine culture as such. Now, trying to convince some the older surgeons may be a little challenging because that's what they've done for so long. Newer surgeons may be easier. Probably try to convince them that. Probably the biggest concern is not so much as them ordering, is that many of these urinalysis orders or urine culture orders are incorporated into an automatic order set.
Right.
That is where the problem is. So when they get ordered, the clinician may not, the surgeons may be unaware of that being ordered, and then they get the results. And as I kind of point out, that abnormal result is the trigger to needing to be treated. So yes, it sounds kind of bad. If they don't know it and they didn't order it, they shouldn't, we should, they shouldn't be done. But unfortunately that happens. And many times this is it happens in ER and it happens in surgery, is that these labs, they're really ordered because out of a convenience, right? They're quickly performed. You can get a result very fast and such. And their hope is that the clinician will be astute enough to pick up on that. The problem is that they don't think of it that way, right?
Right.
But, and then even things like CBC and Chem 7s, my gosh, those are almost ordered at every patient unless it's something really straightforward, like a laceration or something. Many patients get a CBC and a Chem 7 off the bat, right? And the other is that like admission orders to nursing homes. They order that, they have that as standing orders on just having urinalyses and other orders, just so that it's convenient. So you don't have to bug that doctor at 2 in the morning for a UA because the urine smells bad. And that's kind of what one of the challenges is, trying to break away from this, because those abnormal results is what triggering antibiotic prescribing behaviors.
Mm-hmm. Good, thank you.
Let's see. Next question: resources to provide to the providers as education, urinalysis, and interpretations. So there are a number of that. Let me see if I can find some. And I'm assuming you're asking for like handouts or videos. I could tell you that Shay had done some videos on that, some really snippet about urinalyses, trying not to avoid treating urinalyses result without any clinical correlations. But let me dig through a little bit more if there's anything more updated. But yes, and I'll keep in mind, clinicians are great. Education can only go so far, and it's the education is essential to explain the rationale of any intervention, but intervention alone to just try to nudge your clinician is not successful. That's why we, for antibiotic stewardship, that's why ID pharmacists are always busy, because they have to, you can't just tell them, they have to also nudge at the same time. So the same thing with diagnostics. And there's, as we're kind of in future discussions, we can go through different strategies that have been used, but one of the most common is those computer clinical decision support tools, like reminders that pops up to tell you, okay, your patient, if you're going to order a test, then when you order a test, a window pops up and give you a reminder, like CDEP, for example. Okay, your patient is on laxatives. Are you sure you want to order that kind of stuff? Because even if you tell the clinician you shouldn't order it, if someone's on laxative, they'll still do it. But having these reminders reinforce that education. So there are also, and then depends on how well, and one of our challenges here at Building Clinic is that we have a slew of new clinicians. So you can only do so much educating at one time. So you sometimes you're just going to have to put in more restrictive interventions where you're going to say no. Either you kind of treat it like you have to have pre-authorization and such. Unfortunately, that also requires resources to be able to do that. So you gotta have to kind of play around to see how that will really work at your facility and with your clinicians. So anyway, so we certainly can have a kind of a presentation in the future to kind of talk about some of those diagnostic stewardship interventions.
So it looks like Colleen had some questions, if she could unmute.
Yes, this is Colleen. two very quick questions that you kind of alluded to, but didn't give specific criteria. So we're reevaluating our reflex criteria, and we have a pretty low bar to meet as far as how they can reflex to a culture. So we do a lot of cultures.
Mm-hmm.
So I'm just curious what your criteria is at Billings Clinic, and then my other kind of stupid question is when you're looking at, you know, quality of your urine collection, number of epithelial cells, what's your trigger for saying, I wonder if that was really a good clean catch?
So to let you know, we end up choosing somewhat, not completely arbitrarily choose like I think a cutoff of 5, I think epithelial cells, I believe. I have to go back and look at what we decided on, as well in combination with other like abnormal findings to trigger the conditional reflex urine culture. So let me kind of, for all of you kind of understand this, is that something I brought up earlier is that there are several facility, healthcare facilities, their laboratory have chose to use this something to really, and initially it was their intent to reduce the number of urine cultures done, is to have a policy that does is as a conditional reflex urine culture, so that if there's the urinalysis have meet a certain condition, it will reflex. And there's a lot of debate about this. Initially, it was sold as a great idea because it was there to reduce a lot of the cases, but there's a lot of caveat to that. And probably the main caveat is what are those criteria? There are several studies have shown, that they've tried to answer that question. What is the optimal number of white epithelial cells in the urinalysis, or that should trigger that would trigger a specimen rejection? What is the optimal number of white blood cells should be found to trigger a urine culture? And they're looking at this, and there's just really no easy answer, great answer to that, because as you become more, if you lower the number of, let's say for reflex to urine cultures, lower the number of white blood cells, certainly you're going to get a lot more urine cultures. If you increase the number of white blood cells you're going to allow for the trigger, then it will decrease, and you may miss some cases, especially, let's say, for example, patients with who are neutropenic. If they have no white cells, they can't produce any, there's no pyuria. So those tests won't trigger, right? So again, that's one big challenge with the conditional reflex urine cultures, is that there is no magic number, and then you have all these other exceptions, and that's what makes it challenging. But on the other hand, I'm not saying don't do it, because there is still value. But keep in mind that the goal is to try to get as many of the cases. It's not to get all the cases. So you're going to have to do some exceptions for those key stakeholders, such as that's in oncology, oncologists, as part of a neutropenic fever workup, that urine cultures may automatically get ordered, regardless of the UA results, just because, yes, some of those patients may not demonstrate pyuria. So things like that. And I said, I'm happy, I want to kind of give you an overview, and I'm happy to put together some of the specific interventions that's been discussed in the literature. It's just going to take a while because it's a lot more in detail, but.
Okay, I think we are at time. Dr. Koo, Colleen asks if you could please send those recent references that pertain to these UA interpretations, and thank you. So huge thank you to Dr. Koo. I have already received messages that today's presentation was excellent and exactly what people were looking for. So please keep the feedback coming. This really does direct how we host these calls. So thank you, Dr. Koo, so much. Our next webinar will be on Tuesday, November 2nd. We'll let you know if there's homework. I appreciate those of you that did reach out and ask if there was homework for